What's up, you guys? We've got an interesting thread to read. Happy New Year, by the way. And this one is actually by Trazodone Dreams. Are there consultants who enjoy being consulted? I'm about 1.5 years out of psych training. I hated consults in residency because 90% were absolute dog shit, along the lines of patient who presented for any other medical condition, has a history of depression 20 years ago. Can you make sure they can discharge home? Anyway, this had me thinking, is there a specialty out there that enjoys getting consulted? I'd imagine ortho or trauma surgery might enjoy the action, but anyone else get some interesting consults that gets them going? I feel like psychiatry always talks about this all the time. Like, oh, people consult us about people being depressed. They got recently diagnosed with cancer and now they're sad. Can you please see them? I feel like, at least at my institution, I feel like those kind of consults are basically like, people talk about it so much that we actually don't consult psych for reasons like that. I wonder if this is like an institution specific thing, or it's just a thing as the consultant, you end up being exposed to these kind of bad consults, and that's why they stick with you. They're super annoying. But I think in our internal medicine program here, at least, I basically never see a patient who randomly has psych consulted for something that's like a chronic outpatient condition. Now, there's definitely a lot of situations where a patient is admitted and I have like some psych question or something that is like, I think it's kind of outpatient, but I'm not exactly sure. A lot of times I'll just talk to psych and just like ask them really quick, like, do you think this warrants an inpatient consult or something? And it's actually really convenient because the way we consult psych now is we just secure chat them. So we can just message them. We don't have to like do a formal phone call or anything. It's a lot more convenient. Personally, I've been a fan of being able to consult people just via text, but I know there's actually a lot of people who prefer still having that over the phone kind of consult. Let me know what you guys think in the comments down below. Do you prefer doing that over the phone consult, one-on-one, or do you prefer having that time to type out a reasonable consult question and just send it to them and then have them review it when they get a chance? I feel like this part about figuring that the real world consults wouldn't be as bad as residency, that was probably a little bit of wishful thinking there, because honestly, I think in the real world, especially if you're in a community practice, the consults are probably going to be even more soft out in the community. The big benefit, though, is that consultants who are consulted for something very simple, like, for example, somebody has like AFib and it's stable and somebody consults cards for them, cardiology would actually be happy to see the patient because it's an easy consult for them and they get paid. The more patients they see, the more they get paid. But you'll notice that this guy here says that he gets paid a regularly hourly rate for these. So it doesn't really make sense for him he's not really incentivized to doing these consults. I think if you're at places where you're salaried, like at Kaiser, then yeah, you probably have more of an issue of, taking some of these softer consults. But to be honest, my experience rotating through Kaiser as a resident is that in the community in general, people did seem to be a lot more friendly with taking consults, whereas in academics, there is a lot more pushback on what is and what is not an appropriate consult. Anyways, do you guys think there's any specialties out there that do enjoy getting consulted? We'll see what the first answer is. And this person says, I wouldn't say exciting, but more often than not in palliative, I think, oh, thank God they called us. And yeah, I could totally see that. Palliative really can help in a lot of situations where we don't really know how to navigate these really difficult goals of care with people. And I think there's a lot of time that the expertise of palliative is extremely helpful. So I was going to say the exact same thing. Sometimes I get frustrated for a second when a team can't really come up with a true consult question, or when it seems like something they should at least have a go at before consulting, like basic goals of care, or trying something other than Tylenol for cancer pain. But I've come around to realizing people are calling because they need help. And I think that's probably the biggest thing is, I'm not a specialist, but sometimes we as medicine take consults, right? And sometimes the consult question is kind of stupid, or at least it seems kind of stupid. But really, when somebody's consulting you, it's because they need help. And if there's anything where we can just kind of review the chart, see the patient, and just kind of provide reassurance that everything's okay, that's still providing help. I think that's definitely a good mindset to have as a consultant. Sometimes I feel like it's obvious in a way. I have a patient right now in CVI who has a less than 6-month prognosis that will not improve. What is cardiovascular ICU, I'm guessing? CVI, I'm not sure. And is now in karyogenic shock. Oh gosh, those dental cavities must be causing really bad sepsis. Kidding, but that would be pretty scary if there was actually karyogenic shock. With multi-organ failure, and the daughter is adamant on keeping her full code. My consult question to palliative was help. That's a common consult question. It's also hard because it's not like we can just make people change their minds about what they want. And yeah, I see that happen all the time where we consult palliative because we want them to change them to DNR. We want them to change the goals to comfort care and not restorative. But sometimes the family, no matter how much you try to convince them that it's probably better to be heading down that way, sometimes they're still very adamant that their goals are fully restorative. And in that sense, I still think it's helpful to get palliative on board because they can help guide those conversations a little bit better, give the family a little bit of a better picture of why we're kind of telling them, what the prognosis is and how keeping them fully restorative might be bad for them. But, sometimes the patient's goals are just restorative and we have to honor that. Some people really do want to go out in a blaze of glory and their goals are clear and no amount of family meetings will ever change that. Sometimes it's more about empowering teams to not offer futile care. I think that's helpful to know. A lot of times we are not comfortable knowing when we can say, firmly, no, we're not going to provide this level of care or something. Primary teams really should be able to have these conversations with patients in their families, but I've seen that sometimes some teams and specialties just don't seem to have the necessary communication skills. Infectious diseases, probably just playing to type. I don't really know what that means, but I generally have no problems with getting consults. I'm a little bit surprised by that because I think there are a lot of ID questions that are kind of dumb consults or whatever, dumb consults. And I think there's a lot of things that probably annoy infectious disease. But this is the job I signed up for and I really like doing it. I can typically find something to geek out on, even for my most run-of-the-mill bread and butter consults, so I rarely get bored. The best part of my job is the patient interactions, but I'm not a primary provider, so I need referrals to make that happen. I'm not one of those docs that follow every patient they've been consulted on endlessly until they're discharged, so I generally want those calls to come in to keep me intellectually engaged throughout the day. That being said, if I detect even a whiff of some BS, like a SICU team consulted me at the end of a 30-day stay in their unit for antibiotic management, they really want me to do is make a nice little summary of their patient's hospital course for them so they can crib it for their transfer summary to the floor. F that. Do your own dirty work. I will not be your hospital AI bot here on command to clean up weeks of messy charting into a pretty picture. You better believe you're going to get a 2-line HPI along the lines of patient with complicated SICU course due to XYZ. Please refer to prior extensive documentation in the chart. I used to joke in residency that if you didn't want to write a hospital course, just consult ID the day prior to discharge, but I never thought somebody would actually have the gall to do just that. Wow, F those guys. Cardiology here. I know some of my colleagues have a reputation for being difficult consultants, but it's rare that I see a case I can't add something to for the patient care, and the vast majority of what we see is the same handful of conditions that makes the actual work of the consult fairly straightforward. And when it isn't, it usually is something interesting. The frustration with consults almost always is either down to timing or logistics, not the actual medical question being asked. No one likes being consulted at 3 p.m. for a problem that was known to the team at 8 a.m. or earlier, or on Saturday for a problem that was known about on Friday. No one likes the last minute, hey, I'm taking this patient to the OR, discharging them from the ED, but I'm consulting you so we get sued together if this goes south. Yeah, I think those are definitely some good points. A lot of times when I'm doing a late consult, let's say something comes up and it's like 3 p.m. or 4 p.m. and I'm like, oh shoot, I think I had, something came back. I feel like I need to get this consultant on board. Most of the time it's not super urgent and I will let them know, hey, I just kind of want to touch base with you and have this patient added to your list for tomorrow. And, it's not urgent. They don't need to be seen right now, but I'm hoping you guys can see this patient tomorrow and drop some recommendations. Because a lot of times if something comes up at like 3 or 4 p.m., unless it's like an emergency, somebody has like a surgical abdomen and you need to get surgery on board right away. A lot of those questions, like if you have some question for room or cardiology or anybody, really most of the time it can wait until the next day. And I personally like saying, hey, this is not urgent. You can see them whatever time is best for you. I think it's good because even if they see them the next day, they just kind of have that prepped already in their mind that they're going to see this new patient. Maybe they'll do a little bit of chart digging the day before just to kind of review and get a basic idea of what they want to do. I think it's a really good practice to just preface, hey, this is not super urgent. I'm just wondering if you can see this patient tomorrow. OBGYN, this is Dr. Dre or Dr. DRE, and he's a pretty prolific Reddit poster on this residency subreddit. My group is divided. A few of us really don't like doing work more than the minimum. They provide good care, but the veracity just isn't there. The rest of us are all for putting in work, getting the extra RVU, helping out, etc. I like the simple BS consults. 400-year-old brain death woman, 50 years, status post hysterectomy on warfarin drip with vitamin K binders, Q7 minutes with vaginal spotting. I've never heard of a warfarin drip. That sounds like a new advanced technique that we got to learn a little bit about, you guys. But yeah, I'll see that. Recommend against exam under anesthesia until stabilized and offer some comfort to the family and take my 30 cents RVU, LOL. And so this is another prime example of the difference between somebody who's working in the community. Sounds like he's probably more community focused, so he gets actual credit for seeing easy consults. The only thing I ask is that the consulting team is patient. It only bothers me when they place an urgent consult on the vaginal bleeder whose hemoglobin is 9 and she's been in the ED for 16 hours, but suddenly I'm the one holding things up when I'm stuck on labor and delivery for 30 minutes. And so this kind of goes exactly to the thing the cardiologist was talking about earlier, which is the last minute or the timing or logistics causing the frustration with consults. And I feel bad because, you know, the ED is super, super busy, and I don't blame the people in the ED for doing these last minute discharges, or that last minute consults. These things come up. They can't predict everything that's going to be happening. And there's a lot of turnover in the ED. They are switching back and forth between, handing off, between different shifts. And so things get kind of lost in communication. So that's probably why a lot of the consultants get the brunt of these bad consults from the ED, but it's kind of just how the ED runs and how it works. It's not really the fault of the ED physicians themselves. It's kind of a more system-wide problem. That's an upside of working in a setting where you are reimbursed for production. The inter-team dynamics are a lot friendlier because consultations are usually welcomed rather than argued. I make sure that being as friendly and useful as possible to ED and family medicine and all the primary care people, because they're the ones who bump into a GYN problem and say, Dr. DRE is really nice and cares a lot, and that's how you build your practice. Similarly, I find myself sending consults to physicians who are friendly and reliable. I can send my uterine artery embolization patients anywhere I want, but I send them to the doctor that does a nerve block for patients' comfort, gives me a text message status update, and faxes their records without me asking. Yeah, I'll give him referrals instead of the interventional radiologist that makes my life hell when I ask for assistance. Oh my God, yes. This patient's been in my ER all day, but shift change is coming, so you need to see her now is so infuriating. Yeah, it's an unfortunate way. I mean, that's just how the ED works. I don't know if there's any better alternative, because as hospitalists and when we're screening patients from the ED, we have the same problem happen all the time. There's like no admit requests for like hours at a time. And then every time when shift change is about to happen, all of a sudden there's like 12 admit requests all at once. And it just makes the work so stop and go. Like, it would have been nice if it was just coming at a steady stream so we could keep continuing to go through that, that list of patients and getting them admitted. And then all of a sudden you bolus like 12 patients all at once. First of all, the screener has to go see all those patients and determine if they're eligible for admission or not. And then second of all, now you have to have all the admitters go, and they're going to take time, and it's going to back up the throughput of the ED as well. So it's such a fine balance, though, because you also don't want the ED calling too early where the workup has not been completed yet, and they're just like, they don't even have labs yet back, or they don't even have a CT abdomen back yet when there could be a potential surgical problem, and they're already calling hospital medicine for admission. So I get it from the ED perspective. It's really hard for them to tell what the right time to call is. They're either yelled at for being too early or for being too late. Jesus Christ, yeah, in residency, 6:15 to 6:45 was promised 3 consults every day like clockwork. Yeah, and this is exactly what I was saying with the ED. I'm an ER attending, and I totally get that. I try to avoid the end of shift consult because I'm sure it's infuriating. Just to give you the flip side of what we deal with in the ER, though, many consultants are constantly yelling at us for calling too early as well. I can't give any recommendations until the troponin comes back, or what do you mean they haven't gone over to CT yet? It's part of the job, but literally every consultant wants something different in regards to the timing of the consult. I try to consider what time of day it is, whether in-house or on home call. That comes up a lot with our optho consults. I know that ED has to deal with that a lot, but after 5 p.m. or 6 p.m. when the optho people are on home call, they're going to be a lot more snarky if they're getting any sense that this is like a soft consult. Whereas if somebody's already in-house, it's a lot easier for them to see. What labs and imaging might be helpful up front for the initial call, but individual practice patterns are so variable that it's impossible to please Everyone. And so this guy is actually responding. He's an ED attending and a consultant. And he's asking, he's wondering, what is a common consult for you when you get the consult at change of shift after being ignored all day in the ER? And maybe this being ignored all day in the ER is a misconception. He's saying this because he often gets consulted and see the patient's time in the ED to be 16 hours. But when I look into it, they had triage labs ordered at hour 1. They've been sitting in the waiting room for 14 hours. And the ED doc is calling now that they're finally in a room. So really, there wasn't that much of a holdup. It's just the way that the ED works, people are just stuck in the waiting room or things happen very slowly. So it may look like they've been ignored all day for 16 hours, but that's not really the case. As a community hospitalist, I'd say it's a favorable 70-30 for consultants being friendly, collegial, and very helpful. Academic culture, for many reasons, stresses people out and makes them unhappy. It's largely quite a bit better outside of that. And I totally agree with that. I think academic culture, there's something about academic culture that just makes people a little bit more uptight. People are a little bit more judgmental potentially. And so it's good on the one hand because it keeps you on the top of your game. It makes you really consider when you should be consulting and what is an appropriate consult. On the other hand, I think it is a little bit more of a toxic culture. And I'm saying this at an institution that is completely non-toxic. We've got very, very friendly consultants and overall just like, a great system. But I can see how academic culture is a little bit more stressful to a lot of people. Agreed, I am fresh out of residency, but all of the consultants at my community hospital have been very gracious, even if it was a dumb consult for me. Everyone here gets paid on production, so I think that helps, as opposed to the poor cards fellows who were definitely getting roughed up. I'm EM, but in my experience, the consultants I see the most excitement from on consults is neuro. We will get somebody who we think has an internuclear ophthalmoplegia, IDPN, I don't know what that is, Guillain-Barré syndrome, new multiple sclerosis, PRESS, the posterior reversible encephalopathy syndrome, concern for botulism, or even just a weird presentation. I don't know what it is, probably functional. They are probably pretty intrigued in my experience. But I think they're leaving off a lot of what bothers neuro people, which is the very frequent low suspicion stroke alerts. I feel like they don't really like that. Although, I've talked to a lot of neurologists and they're like, if you have any suspicion, if there's any low suspicion for stroke even, you should just call the stroke alert, have a very low threshold to do that. But also the altered mental status ones. I mean, I don't think they'd be that excited by this weird presentation. I don't know what it is, probably functional. I'm not sure they'd be that excited about that, but maybe that is something that neuro really enjoys working up. Neurologists are all a bunch of nerds, and it's honestly delightful. As a neurologist, if I'm not giving off med school study buddy who did the reading vibes, I'm not doing my job. And this totally goes with that Glockenflecken personification of the neurologist, although he's not very friendly. So he definitely has that med school study buddy doing the reading vibes, but I don't think he's particularly friendly. Yeah, this person says, hospital dependent. Neuro is reliably one of the most unimpressed, eye-rolling, push-backy services at my place. That's been my experience at Well. I work in peds, so mileage may vary, but palliative and metabolic genetics are almost always happy to be consulted and are always pleasant to speak and work with. I think it's going to be a theme that anybody in palliative, they usually go into it. The people who are in palliative tend to be like very friendly, empathetic people in general. So even if they are kind of annoyed about the consult, I don't think they'll show it to you. They'll just be very empathetic and helpful. And then metabolic genetics, I've never had to consult them. That's probably more of a peds thing, but because of their lifestyle, I'm guessing, is probably why they'd be like a little bit more laid back. And also they probably have like a very interesting line of work where it's like, wow, like we got to figure out if there is a genetic component at play here, or is there some kind of chromosomal defect or hereditary cause for this patient's condition. I think that's kind of interesting and kind of, fun detective work. Infectious disease here, I enjoy being consulted when there's a consult question. Patient X has leukocytosis and we are worried about syndrome Y because of associated symptom Z, or we see abnormal lab value and our differential is XYZ and want your opinion. Absolutely. So yeah, I think that goes to a key part is when you are consulting somebody, you want to have something in mind for them to work up. Not like that guy earlier who was talking about palliative care and just saying help, but having something specific that you're asking them. Like, hey, this person has concern for endocarditis. Do you think this person needs an TEE to cardiology? Or even just telling them what your thinking is so they have a better idea of what to look for. It shows that you've done some thinking about it rather than just kind of reflexively consulting them. I think consultants would be much more willing to help out in those scenarios. This person says, what I can't stand is the consult order that says white blood cell count 17 and no additional details, and the team gets an attitude as I try to pry information out of them, followed by them trying to argue me out of my recommendations, which really means they should have never gotten us involved, but it's too late now. Sounds like someone has finished just another consult on a post-op CT surgery patient with Dressler's pericarditis that's been on daptomera mica for weeks, and the CT surgeon just can't believe it's not an infection. Tale as old as time. My favorite was fever of unknown origin in a post-op cabbage patient. Go see patient, vein harvest site red and leaking pus. Do a few sternectomies and kill a few routine cabbage patients for sternal wound infection, and you'll become insane. That shit scars you. So I always feel, it's a really great point. I love seeing the comments on Reddit because there's always two sides of the story. And, you have a routine cabbage patient, they die from an infection. Of course, that's going to change the way you practice and lead you to have a very, very high index suspicion for a possible infection, even if objectively speaking, the concern is lower. So again, always, two sides of the story. I hated literally everything in residency. It's all different once you're out. Hell yeah, I'm geriatrics and I love the consult. I automatically see all geriatric trauma at my center, but I'm certain that I improve care and communication and reduce polypharmacy, as well as manage delirium in the formal consults. It's never drudgery, and it's not like having to see 20 venous stasis every day on ID consult and say hold antibiotics. There are definitely, I already mentioned this before, but there's definitely certain specialties that probably just have a fun time all the time. They're just like happy to be consulted all the time. We rotate through geriatrics during our residency, and it was pretty fun to just see the patients because even if there wasn't that much to do, you could always find some medications to optimize, or even just get the patient's hearing aid and vision aids to reduce their delirium risk. It was just little small tweaks in geriatrics, but they all felt very satisfying, especially because a lot of it is removing potentially harmful things or reducing polypharmacy. I could see why geriatrics is just kind of rewarding. And honestly, there was a part of me that was kind of interested by it. I don't think I could give up all the rest. I just like all the other stuff as well. I've always talked about how I, preferred being a generalist because I just love being able to put in to use all of the stuff that we learned through medical school, or at least most of the stuff, obviously not peds or, OB for me. But geriatrics seemed super fun. It really seemed really fun. And I did think about it as a possible career option. Nephro, I like it. Very obviously, we get called about every ESRD patient. And if you aren't cool with that, this is a bad field for you. But the other ones are typically interesting or easy. I'm always happy to get a glomerulonephritis, weird acid-base thing, toxic ingestion, etc. And doing a straightforward AKI consult is pretty fast. And yeah, that's one thing they say when you're going to choose your specialty. You don't choose the specialty based on what the most exciting and fun thing is. You have to consider what the most mundane and the most typical thing that you are going to be seeing is. In this case, for nephro, it's going to be those ESRD patients who just need their chronic hemodialysis while they're in the hospital, which is probably a kind of boring consult. I rotated on nephro twice while I was a resident. But really, yeah, the exciting things for nephro are truly quite exciting. I think GN, acid-based things, those are really exciting things to be consulted on. I've learned that psychiatrists actually just hate being consulted. That's what I'm saying. I don't know how much, we always talk about so much about how psychiatry gets all these chronic depression, outpatient management kind of consults. Although in my experience, I feel like I've never given that consult. I've never seen patients come in with those consults. So I just wonder how often this is actually happening to psychiatrists. But I like this guy's response. I personally love an appropriate psych consult, but I'd say greater than about 30% of consults we get don't even contain a question. Sometimes it feels like people will think we're around to deal with emotional issues the primary team doesn't want to handle. So look, the things that you want to consult psych for, really it's going to be acutely psychotic patients, people who are actively suicidal. They need to be put on a 5150 hold or whatever the equivalent is in your state. Possible inpatient psych discharge after they're medically cleared. Like I said, psychosis, active psychosis, hallucinating. Those are all things that psych should be on board for. Catatonia, I've had a couple of cases of concern for catatonia. So those were fun psych consults for me. So yeah, definitely not that post-cancer diagnosis, patient feels sad question. That's not an appropriate psych consult. Probably because the vast majority of consults are atrocious. Like, I'm not calling the medicine team to resume the lisinopril home med on my patients. Why am I getting called for somebody on Lexapro 5 who's asymptomatic? Oh yeah, another good time I sometimes consult psych is when there's concern that they're getting side effects from their medication, or if they had like serotonin syndrome related to it and they need to be titrated to a different regimen. That's probably something that needs to be done inpatient. So that's probably another reasonable consult request for inpatient. Radonc here, don't mind getting the consults, but the late Friday afternoon cord compression when they've had symptoms all week and the MRI the day before drives me crazy. So again, a timing issue with the consult. Hepatology, I'd rather be called for every cirrhosis patient versus not. Most hospitalists are unaware that some centers will transplant people who recently drank if they meet certain criteria. Need early consultation and discussion. Interesting. I read this and I was quite intrigued by it. I really don't feel like they would be able to handle the volume of us just consulting on every single cirrhosis patient that comes in. You know, we calculate the MELD score. We see how elevated it is. I try to look through a chart and see if anybody's talked about transplant in the past. But I'm curious about that one. Do they truly want us to consult on every single cirrhotic patient? Somebody comes in with hepatic encephalopathy. They've not been taking their meds. Yeah, I think early transplant evaluation is useful, but I also don't think they would be able to have the capacity to handle consult on every single cirrhotic patient that's in the hospital. Let me know if you feel differently. I'm a PGY4 in psych, and I like being consulted on most days unless I'm already slammed with a big pile of them. So a lot of psych coming in through on this thread. It's something that really needs psych. Again, like the active psychosis, like I mentioned before, or active suicidal ideation. And I feel like we make a difference to patients. Or it's something small. Patient seems sad on the ward, has mild, moderate anxiety coming through the ER, and it's super easy, but I still feel like it helps because I could either validate someone's perfectly normal emotional experience or refer to counseling or start a quick antidepressant. These encounters still make a difference for a lot of patients and put the referring doc's mind at ease so they can focus on their stuff. So this guy is a super friendly psych consultant. This guy basically is taking all the consults and he's being happy with all of them. So that's very, very nice. He has a very wholesome name too, The Quest for Starfish. Sometimes I wonder how people come up with these names. They're so cute. The Quest for Starfish is so random. Oh yeah, but one thing I was going to say about psych is when you do get psych involved, make sure you preface or you tell the patient first that you're getting psych involved. Don't do that thing where you just leave the room and then all of a sudden psych person arrives and the patient is like, "What? You called psych on me? You think I'm crazy?" Wow, I don't know, that was a little weird. But yeah, give the patients a heads up that you're thinking about getting the psychiatrist involved and try and gauge the response beforehand because you don't want to just spring psych on them all of a sudden. That could be really damaging to your doctor-patient relationship. Part of the problem of bad consults is the trend towards very high census for hospitalists. I'm a nocturnist now and just do admissions, but when I was a day hospitalist in an open ICU with census greater than 20, I had more consults because on some days it was difficult to safely take care of greater than 20 patients, a quarter being critical, all on my own. That is a really crazy census. I mean, here in this area that I'm working, I would say most of the practices here seem to have an average of around 15, 16 patients. UC Davis is a little bit lower on that side, which is helpful. And then Kaiser, they have shorter shifts, so they're even lower as well. But yeah, if you're taking care of 20 patients, it truly is a case where the more patients you're overloading onto your hospitalist, the more they're just gonna have to defer that work outside to other people, and you're gonna get worse consults. That definitely makes sense. They usually weren't complete bogus consults though, and I will call them if I just had a question instead of simply placing a consult order. Trauma surgeon can confirm I love those level 1 traumas. Get a job that's RVU based, consults equals money. At an academic institution? No. All right, I think this one here does a good job summarizing a lot of the pain points that consultants have when people consult them. So, room fellow here, I think there's a few components to this. I generally am more accepting of consults than my colleagues just because I did my training here, and I was always appreciative of the nicer fellows. However, there are some consults that irk me. I think a huge chunk is pay. If I was getting paid or getting RVUs for consults, I'd be happy to see any consults. However, when you are a fellow in training, there's some things that really irk me. Logistics. When you call after 3 p.m., let's face it, there are almost no rheumatologic emergencies. But if you put it in after 5 p.m., I'm basically at the behest of my attending, who usually wants to see the patient. So then I'm left scrambling in the middle of rounds to chart the patient, evaluate the patient, staff it, write the note within an hour. When there's 2 or 3 of these, say goodbye to any dinner plans. Lack of a question. I'm lucky that the majority of patients here are fantastic and have a question in mind. However, that said, there's still a chunk that love to ask the history of positive ANA with no question. I've come to expect that from some services, but when it comes from medicine, my heart just aches sometimes. Gotta love the medicine teams that have consults of patient has history of RA, some connective tissue disease, not on treatment, admitted for no question. Ignorant of the elephant in the room. Patient with septic arthritis has a history of rheumatoid arthritis. Is there also an RA flare? How about treat the elephant first? And then lack of contact, no callback, no info how to reach the team in notes. I see this a lot. I don't want to call out anybody, but all right, maybe I won't call anybody out. But yeah, the best ones are always a combination or even all of them. Lack of questions at 4:50 p.m. on a weekday for a problem that has been ongoing for a week without any way to reach the team to clarify or give recs. I love that. Perfect. The perfect storm of the worst consult ever. Can anybody devise the perfect worst consult in the world? Let me know in the comments down below if you've had an experience like that. All right, you guys. So that was fun getting to look at what consultants consider when they're receiving consults and if any of them truly enjoy receiving consults. I think there's a lot of insightful perspectives there, a lot of back and forth between seeing 2 sides of the story. But I hope you guys enjoyed this video. I'll see you guys in the next one and hope you have a great start to your 2025. See you in the next video. Peace.